Hello, I'm going to present on enhanced recovery after surgery, also known as ERAS. The objectives is to recognize the need for the ERAS protocol, be able to describe the ERAS elements, and utilize ERAS elements in the clinical practice. As a background, in 2017, they noted 1 out of 4 people having an operation will experience a complication. In 2017, we had about 22,000 members that had operation. So these are some of the surgeries that could happen. They noted that there was about 15% who had 50% who had complications. This could include UTI, sepsis, infection, bile leak, pneumonia, abscess, bleeding, fluid overload, ileus, and more. So they decided to have an implementation of the ERAS protocol to reduce complications and to improve outcomes. And what was the whole point was for the patients to get better faster. So how does this look like? One is to use multimodal preoperative care pathways to designed to reduce physiological stress, improve recovery, and reduce complications. It also was evidence-based practice or is evidence-based practice, and it also is focused on patient-centered care. ERAS is also characterized by a whole team involvement. This includes audit of compliance, outcomes, and all of the different departments that work together to prevent these complications. So the key elements of ERAS is one, in pre-op, they do counseling, making sure that they have the optimal nutrition, cessation of tobacco or alcohol use, and then there's no NPO after midnight, but instead they do a load 2 hours prior to surgery. They also have standard anesthetic management and their goal-directed fluids, also multimodal analgesia, VTE prophylaxis, early PO intake, and early ambulation. So the benefits of ERAS was that they had better outcomes. This actually reduced complications up to about 50% fewer. They had shorter hospital stays up to 30%, and of course, it helped decrease the costs. So the benefits of ERAS were one, the pre-op carbohydrate drink kind of helped it with avoiding the starvation, patient satisfaction, decreased nausea and vomiting, kept the gut stimulated, preventing muscle weakness, and decreased insulin resistance. Multimodal analgesia helped improve patient control, minimize narcotics, decrease risk of delirium, nausea, and vomiting, and post-operative ileus. The early ambulation decreased the risk of DVTs and PEs, as well as post-operative pneumonia and post-operative ileus. And early nutrition helps stimulate the gut post-operatively. It decreased the risk of post-operative ileus, helped also return to a normal physiology, and it also helped with shorter length of stay. So the patient population for ERAS is anyone that's having an elective surgery. At the present time, patients that are less than, adult and pediatric patients who are present for elective general, orthopedic, gynecologic, urologic, vascular, plastic, neuro, and head and neck procedures are included in ERAS. This does not currently include patients undergoing most emergent procedures, patients under the age of 14, as well as elective cardiac surgery patients. So the enhanced recovery checklist, like I said earlier, it takes a whole team. Um, And it also starts with pre-op, and it comes down to intra-op, PACU, and then the inpatient setting. So in inpatient, we focus on three different components. One is the early feeding intake and the ambulation and mobilization of the patients, as well as using multimodal analgesia and antiemetics. So, how do we meet our goals? We must identify these patients that they are an ERAS, and how we can do that is looking at the hospital ERAS list, and we have to look at the four metrics for your patients, and we must make sure we document within 12 hours out of the OR exit time. So one thing, or the four things that we need to look at is liquid adherence, early feeding, ambulation and mobilization, and antimodal analgesia. So this is our ERAS workflow. In PACU, we have a ward clerk by 7 o'clock sends a daily list of patients that will be having surgeries to the inpatient units. Our leaders will get that list, and they should be able to identify which patients are utilizing this ERAS protocol. For pre-op nurses, we want to make sure that we identify the NPO status of the patient. The physicians must order an ERAS order set, um, and the PACU RNs also need to initiate the ERAS elements upon their arrival to OR. And this is the ice chips or water, assisting patient or ambulating, and on the report, the OR, and need to report the OR exit time to the inpatient RN. For inpatient, the patient will arrive, and we would like to place laminate E on the patient's door frame, which specifies the OR exit time of the patient. We also need to document on the OR checklist and indicate the early feeding intake and ambulation and multimodal analgesia. We then need to document it in Health Connect, and once the 12-hour OR exit time had passed, then we will take down the laminated E from the doorway. For our patient outcomes, they also are shared with the list for ERAS, and they also will validate the documentation or do audits of the validations for the NPO status of the liquids, early feedings, diet ordered in place, and ambulation. So for patients who are going to have are inpatient and going to have surgery, the doctors must place an order. And these are some of the examples that the orders may look like. So the orders can be clear liquid after midnight, and notice that some of the start time is at midnight. They then should have a NPO and a diet for NPO accept meds, and they also must have a order to have a carb load given 2 hours prior to surgery. So what this is looking at is that most of our patients at the time, they don't eat so much, or they have been NPO for a long period of time, and so we want to give them a carb drink 2 hours prior to surgery. This has to be in order, and we usually will not give these carb drinks for patients who are diabetic or have delayed gastric emptying. We would give 8 to 12 ounces of water instead of our carb drink. The starting drinking of carbohydrates supplements is 2 hours prior to surgery to be consumed within 15 minutes. Once we give them that carb drink or the water, we then must make sure the patient's NPO and document the time the patient was NPO. So this is when the nurses know that they can start their surgery 2 hours once they're at NPO. So what are the different carb drinks that they can have? It could have the Gatorade or Powerade, apple juice, Clear Fast, or Gatorade Prim 2 pouches. And again, remember, for any patients that are diabetic or have a gastric delay, we want to make sure they only have water, and this is only 8 to 12 ounces. So in our pre-op checklist, we must write NPO status and when they had started their NPO. And again, it has to be 2 to 5 hours um, of when they were NPO. How do we document a diet? So let's just say a patient had come back from surgery and the patient has a diet order for clear liquids. So we want to make sure that we document the nourishment given and the diet percentage as well as the in PO intake. So if a patient is going to have a clear liquid diet of dinner, we want to make sure that we also have the percentage and how much in mLs that the patient had taken. Let's just say if a patient actually came at 4 p.m. and dinner is at 6 o'clock, 4 p.m. they asked for a glass of water and you offered them a glass of water and they only drank half of it. Technically, because the water is clear liquid, that is considered nourishment. And so if you're going to give nourishment um, at 4 p.m., the nourishment would be considered a snack. And the diet percentage of that snack should be 50% if they drink half of the glass water. And usually a cup is about 240 mLs. So if they drink only half of it on the PO mLs, I would document 120. Now, if the patient then at 6 o'clock had dinner, we would want to make sure that the nourishment that the documentation would be dinner. And if the patient only had 25% of their meal, then we'll have diet 25%, and then we'll put how many mLs all in all they drink under the PO ml. So documentations that are also required is making sure that we document the multimodal analgesia. So you need to administer at least 3 multimodal analgesia medication preoperatively per a physician's order. And then post-operative, they want to continue the multimodal analgesia as ordered. And this includes our acetaminophen, gabapentin, Decadron, Mobic, Advil or Motrin, and then Toradol. For mobilization or mobility or and ambulation, we must make sure we document that the patient had ambulated or mobilized before 12 hours of the OR, within 12 hours of the OR exit time. So we want to make sure we document the activity management, the distance walked, and also the activity distance provided. So one of the things we want to do to make sure the patient can get up is also do a quick assessment. Ask the patient, were they able to walk prior to surgery, and if they have any assistive devices. Then we can have them lift their right arm, their left arm, and if they're able to lift both arms, you know that they have strength in their arms. We then ask them to lift their right leg and their left leg. If they're able to do that, we know they have some strength on their legs. So then we can have them sit, dangle at the edge of the gurney or the bed. We'll have them take a couple of deep breaths. If they start to waver off, can go ahead and place them back into bed. If they're sitting up straight, ask them to take a couple of deep breaths and then have them scoot to the edge of the bed. Make sure both feet are flat on the floor and then um, make sure the patient's not dizzy. Then you can ask them to kick up their right leg and their left leg. At that time, you can see that the patient may have some strength on their thighs, right? So here at this time, if they're safely able to sit in bed, you can then pre-plan and put your IV poles around to the side that you think the patient will get up out of bed. And so make sure, I highly suggest to use a walker to place in front of the patient before they get up. So make sure you have, or you're pre-planned, you have the IV on this side, the patient's getting up, you have the chair available, and so you also have the walker in front of the patient. Then you can check if the patient can kick with both feet. If they're able to do that, then you can have them stand up using the walker and just assist them up. I really highly suggest to use a walker so they don't pull on you. Once they stand up, have them take a couple of deep breaths and have them um, lift up their right leg and then their left leg. And if they're able to do that, then you can pivot them to the chair. So that's how we got them from a mobility 1 to a mobility 4, because that one step is considered less than 1 to 20 feet. So exclusion criteria for ERAS. The diet intake, if the patient has an order for NPO, an NG tube is placed. Also for ambulation, if the patient's baseline mobility is a 1 or 2, these are criteria for exclusion of ERAS. So finding the OR exit time, there are 4 easy steps. You can go into event management. There you can choose the correct patient, and then you can look at the encounter events, and you can also note the patient's um, exit OR time, or they would say also patient out of room time. This is how the laminated E sign should look like. We should post this on the care board or even on the doorways, wherever you guys decide, but at least everyone's aware that this patient just had surgery and we have 12 hours from that time to do the elements of ERAS so we can prevent these complications from happening. So that is it for this presentation. Thank you, and let me know if you have any questions.